Good afternoon. I heard I'm the only speaker in English, so hopefully that's not a problem. My name is Wouter Heenkamp. I'm a gynecologist from a university hospital in the Netherlands, the VU Medical Center, and we have some experience now with elastography and benign gynecological disorders. There's not too much time anymore, so I have to skip through some of the slides somewhat more quickly. Why would we even perform elastography for benign gynecological disorders? Well, if you make this image and you think it's a fibroid, you could plan a laparoscopic resection of this fibroid, which is in this case true and goes without any problems. But what if it turns out to be this case, that it's adenomyosis and it turns into a surgical disaster? So that's why you would want something that differentiates more easily between fibroids and adenomyosis. This could be the image. I will explain to you later why this is a fibroid, but this is the image that makes us believe that this is indeed a fibroid. Whereas if we would have seen this image, we would have known that it was adenomyosis. So that's why we would like to do this. This was already shown by the previous speakers. So the more reddish yellow is soft tissue, and the blue purple is more hard tissue. In case of a fibroid, if you compress it, you would expect it not to deform that much. So that would turn out to be quite purple. The uterus somewhat more blue. Adenomyosis is softer, so that's, somewhat light blue. And bowel is, of course, very soft, so that's yellow towards red. In a normal uterus, we would see this. You can see the lining pretty clearly. The bowel is surrounding the uterus, of course, and the endometrial lining is lighter also. So the wall of the uterus is purple, and that should be your 0 when you look at this scan. It's very important to get a steady state image. Steady state means that it's reproducible. So it's not an image that you just see for, let's say, a split second and you just turn the stop button and that's it. But you have to keep on seeing that on your screen, and that's a steady state image. You can either do that by baseline. That means you hold the probe, the vaginal probe, still against the uterus, and the movements are made by, let's say, breathing of the patient or the heartbeat or something like that. Or you have the dynamic steady state, and that means that you make the movement with your probe yourself. So you go in and out the vagina with the probe, not in and out, but like very gently. You have to explain, of course, what you're doing, otherwise it's a bit of a strange thing for the patient to notice. And that usually defines the image somewhat more, and it makes it more easy to distinguish between a fibroid and adenomyosis. I will show that to you later. Hopefully this is working. Yep. So this is what you see at a baseline image. We can see an abnormality here near the fundal area. And what I'm trying to do is to make this steady state image. And what you can see in the elastography image, that you see an area that's somewhat lighter here. So it could be adenomyosis. But now I'm not doing something really with my probe. So I'm doing the dynamic one now. So pushing my probe in and out towards the uterus. And then I see this. So making gentle movements, and now you can see more clearly if you just wait a little bit, because it always takes a little while to get a steady state image. Then you see here that it's clearly more light, and that's indicative for adenomyosis. And that indeed it turned out to be, because we made an MRI scan also to confirm the diagnosis. This is an example without a steady state. On the left, the grayscale image, you can see the fibroid in this case, and on the right side you could say this is adenomyosis, but it's not steady state because you don't see the serosal lining very well. This is what you should have seen. So this is like the baseline steady state image, and there you can see quite clearly that it's probably a fibroid. Whereas if you do the dynamic steady state, you can see the serosal lining very nicely, but also the lining of the fibroid itself. So we did a feasibility study to see how reproducible our outcomes that we thought were there. in gynecology, and we looked at diagnostic accuracy, additional value, and a comparison to either pathology or MRI scanning. Well, I'll just go quickly. What we noticed is that the uterus had, the serosa had small bright lines like a rainbow, and the myometrium was purple or dark blue, what I explained to you before. So you can see that here. The lining, if you enlarge it, you can see the rainbow there. So that needs to be there in order to say that you have a steady state image. Fibroids, the center is dark. The capsula has also the regular bright lines, as you could see for the serosal lining of the uterus. And sometimes you see necrosis inside the fibroid, which is also softer, so bright yellow. Here you can see an example of the capsula of the fibroid, also with the rainbowish lining. And here you see a soft spot within the fibroid with a nice lining of the serosa of the uterus as well. Adenomyosis is, you don't see the delineation very well. It's, I mean, you could compare it to a pathological specimen, and there you would expect it to be more irregular, and sometimes there's no delineation at all, and then it could be diffuse adenomyosis. This is what you can see there. So you see the endometrial lining here in the middle, and you can see like diffuse lighter spots in the uterus. And this is more focal adenomyosis, where you can see in the anterior wall an area of not very well defined, but still adenomyosis in there. So this is how it compares. We see differences. Well, I won't say them all, and you can find them in the article that was accepted in the White Journal. I will explain to you later. This is what we did to compare the diagnosis that we did with elastoscan to MRI or histology whenever it was available. For fibroids, histology and MRI was always confirmed in all cases. Adenomyosis, a little bit more rare, of course, was also almost always confirmed. And the combination, which happens a lot too for fibroids and adenomyosis, was also confirmed. I'll just skip this one. Also, sometimes the delineation of the fibroids is better. On the left side, you're not really sure, is this like one fibroid or are there multiple? And with elastoscan, you can actually see that it's 3 different fibroids there. Sometimes also, well, like in this case, you can see where the fibroid ends exactly compared to the normal myometrium. And also to measure the residual myometrium. If you want to do a laparoscopic resection, it's important to know how far you should go into the serosa before you're at the fibroid, because sometimes it's pretty hard to distinguish surgically. And that's also something you can see quite clearly. 2 small things to remember if you do the scanning. There's movement artifacts. You don't see the serosal lining very well. Whereas you should have seen this. This is a lot better. And you have the probe artifact. There's always a lighter area anterior to the probe, and that's not adenomyosis, that's just the probe artifact because of the movement. Well, as I said before, this was published, our results on this in the White Journal, Ultrasound Obstetrics and Gynecology, just this month, and they liked the image so much that it was on the front page of the issue. As you can see right here. So to conclude, we confirmed the diagnosis, so either fibroids or adenomyosis or the combination in almost 100%, and there was a subjective additional value when it comes to delineation and the distance to the serosa, and it made it easier to differentiate between fibroids and adenomyosis. Could be an alternative to MRI, which is of course a lot more costly. But we're still in a learning curve. We have to optimize the settings. We're just finishing an inter-observer study, which is very important, of course. If I can make these results, that's very nice, but can you make the same? So that's what we're analyzing at this moment. And hopefully I will be able to tell you more about that on another occasion. Thank you very much.